At our board meeting about your topic, and we're excited to hear what you have to say, and I'm excited to see beautiful slides. So thank you so much for taking the time to be here this morning, and please join me in welcoming Dr. Emily Putnam-Hornstein.
Okay, thank you so much. I am thrilled to be here to meet all of you. I have to say that I am also a little bit tired because last night I decided to go to the website and discovered that in fact you guys have been recording a number of these talks, and they were actually totally fascinating. So I found myself staying up late and I watched the talk, I think Leslie Orloff, and Susan Love, and a few others I kind of jumped into. So I'm really appreciative of all the work that you guys do out in the field. Just by way of background, I was a child welfare caseworker in New York City before moving out here to California and going to Berkeley where I did my PhD. I think if you'd ever told me 10 years ago that I would be on the research side of things as opposed to the front line, I would not have believed it. So while I will be standing here presenting research and data and charts, I hope it will be interesting to you. I think it will be. One of the things that I found in my frontline work was that I was often missing that broader understanding of how my clients and my cases fit within the broader population of children who were victims of abuse and neglect. And that was actually one of the reasons I decided to go specifically to Berkeley. The data that I'm going to be presenting today all comes from throughout California. And I'm going to talk a little bit about the nature of that data and how we've used it. Before I do that, I also want to say please jump in with questions throughout. I'm not sure what the normal format is, but particularly when I'm kind of walking through slides and data, if something's not clear, please just jump in with a question. And before I start, I just want to acknowledge my colleagues at the Center for Social Services Research, as well as the California Department of Social Services. So I get to kind of present all of these data, but there are many, many bodies involved in the work, and our funding is received from the California Department of Social Services as well as the Stewart Foundation and Casey Family Programs. And then the linkages that I'll be talking about was funded by the Harry Frank Guggenheim Foundation. Okay, so let me just begin. Who here has been to the Performance Indicators website or looked at any of the data that we have for California or the different counties? Has anyone been there before or not? Okay, well, it's a great resource, so I hope that I can encourage you to go kind of at some point in the future. But basically what happens is when a report comes into a county hotline, that report is logged, the investigation, all of the outcomes that follow that report are entered by county child welfare workers. And all of that data is then sent up to the California Department of Social Services. And those data are then shared with UC Berkeley under a long-standing agency-university partnership. And what we do with that data is we configure it longitudinally. And what that means is that we have information for every child in California who was reported for abuse or neglect from 1998 through until 2012. And we can look at kind of how they interact with the system. So we might see that a child was first reported for neglect as an infant in 2000. Maybe there was an investigation, but the child was not removed from the home. Maybe 3 years later, another report comes in. This time, the child is substantiated as a victim of abuse, and they enter foster care. Maybe they're reunified, but then they re-enter. So what we're able to do is take all of this data that comes from all the counties and track children over time. So what are some of the kind of big picture trends that we are able to kind of appreciate as a result of these data? And I promise I will not be showing you too many charts, but I just want to kind of start here. So one of the big stories in California, for those of you who don't know, is that our caseload of children in an out-of-home foster care placement has declined dramatically over the last 10 years.
So if you look back in 1999, that's when it peaked at around 110,000 children. So we had 110,000 children on any given day in 1999 who were sitting in an out-of-home foster care placement. And as you can see, that dropped over time such that today, or a little bit kind of 2 years ago, I guess, and it's continued to decline a little bit further, we have around 56,000 children in foster care. It's interesting because most people assume that that decline in children in foster care is the result of reductions in entries to foster care, but as you look at these other two lines, you can see that's actually not true. The entries rate, which is that blue line, has declined a little bit starting in 2007, but other than that, it's been pretty flat. So unfortunately, despite our best efforts, we have not been particularly successful at stopping children from entering foster care. But what you see is that while we also haven't seen a steep increase in exits, what you can see is that over time, the rate at which children were leaving the system as an exit was higher than the rate at which they were entering the system. And so what that means is that over time, we've slowly been decreasing our overall out-of-home population. That's the result of improved permanency efforts. You have to remember that back in 1999, prior to that, we had a lot of children who really had been growing up in foster care. And so what we've seen is that the exits is partly a result of doing a better job of moving kids quickly to reunification or adoption, and it's also unfortunately because we've had a lot of older children who are exiting out. So that's one thing that we can kind of tell from all the data. Something else we can look at is we can look at the topic of racial disparities. Looking at this chart right here, you can see that we have the overall population in California. So this red part of the bar here, 5.9, that represents Black or African American children. So you can see that in California, the overall population of Black children is around 6%. White children, it's around 28%. Latino, 54%, Asian, 11%, and Native American, 0.5%. So we know that. And then what we can do is we can look at, okay, what share of all children reported were African American, white, or Latino, substantiations, entries, so we can look at that data. Okay, so we have a lot of important indicators that can be computed from these data, but there's a whole lot that we are not able to tell from this standalone child welfare data. Oops, sorry. And that comes down to the iceberg. I'm guessing many of you have seen this iceberg picture before. It's kind of the classic generic analogy, but I think it works well, which is you have this tip that emerges above the water, and those are the children who are maltreated and they're known to Child Protective Services. And then you have the rest of the iceberg, probably a much larger share, which falls below the water, and those are children who are maltreated but not known to Child Protective Services. And all of the data I just showed you that gets entered by social workers, that gives us information about the tip, but it doesn't give us any information about the rest of the iceberg. So when I arrived at Berkeley, I realized that, and I realized that there were a whole lot of questions that I had surrounding maltreatment and child victims that I couldn't answer using that data. I had what I would call a snapshot of victims. We had the information about those children who were reported, but we knew very little about what those children and families looked like before that abuse had occurred or before they had contact with the child welfare system. And we also knew very little about what their outcomes looked like after they stopped having contact with the child welfare system. We knew, did they re-enter the system perhaps, but we didn't know how they fared in other domains, education, mental health, well-being generally. And the other thing that we didn't know is we didn't know anything about those children who were not reported for maltreatment, who may have had similar risk factors, but also had some protective factors that meant that their families were able to function in a way that the children were safe from harm. So what I set about doing was taking those Child Protective Service records that I was just telling you about, and we have over 10 million records up at Berkeley over that course of 1998 through 2012, and I started linking them with other population-based data sources. To get kind of that before information, what I did is I took records and I linked children who had been reported for maltreatment back to their birth record, so that we had information as to what they looked like on the day they were born. In terms of what they looked like after, I took vital death records and I linked those up to child welfare records so we could see, of those children who were reported to CPS, did they experience higher rates of preventable injury fatalities, inflicted injuries, unintentional injuries, other types of deaths. And then by linking up with the birth data, what that meant was we had information about all those children in California who were born here but weren't reported for maltreatment, but yet at the same time may have looked very similar on the day of birth. Just a quick kind of record linkages 101 in terms of how this was done. You can imagine having two files. That first file, those are birth records. The second file, those are child welfare records. And we're looking to find individuals who are common to both files. If we had social security numbers in both files, that would be pretty simple. Okay, we could literally just look up every child who was reported, look up their social security number, and link them back to a birth record. But of course, children don't come out of the womb with social security numbers assigned, and in the child welfare data, we only had social security numbers for around 60% of the children, which meant that we had to use an alternative methodology called probabilistic matching. And what that is it means that you can take several different non-unique but personal identifying fields and match individuals who are likely to be the same across data sources. So it means that we could use things like first name. Maybe in one file we have a complete middle name, but in another file we only have a middle initial. We can use last name, date of birth, maybe we've got a full address and a zip code. And basically, thank goodness for computers, because what this is it's a software program where it assigns a weight to two records based on the likelihood that it is in fact the same individual given the fields that you've specified. So what that allowed me to do is take these birth records and link them up with CPS records as well as death records. So in terms of kind of the total number, whoops, sorry about that. Think of it this way. We had 4.3 million births in California between 1999 and 2006. So I had all of those birth records. I linked those up to the birth record, or to the child welfare records of all children who were reported for maltreatment before the age of 5 and had a date of birth that indicated they were born during one of those years. That ended up being around 514,000 children. And then I linked up with around 25,000 death records, of which 1,900 or so were injury fatalities. So while the numbers are not necessarily important, the way to think about this is that it allowed me to look at 4 different groups. The first group were those children who were born in California, were never known or reported to CPS, and didn't die. So we see them at birth and we don't see them again. The second group, children who were born in California, they were reported for possible maltreatment before the age of 5, and they didn't die. The third group were children where they were born in California, they were never reported, but they did die before the age of 5. And then this last group is the group where they were born in California, they were known to Child Protective Services, and unfortunately they did also die before the age of 5. And so those were kind of the 4 groups that we were able to look at with these data. And before I kind of get into what did we find and what are the implications for practice and policy, I want to just step back and say that I think that the way this whole research is being framed, and I think appropriately so, is that this is really taking a public health approach to the prevention of child maltreatment. So public health approaches, public health researchers are really focused on what is the health of the overall population and what changes can we make that would possibly shift the distribution of risk and protective factors. And it's something that in the field of child welfare and in the study of child maltreatment, we are just beginning to do for a few reasons. One is that we have had the limitation of only having that standalone, what is sometimes referred to as a silo of child welfare data, that frankly we haven't been linking with other data, even though we might really want to know how many of those families who are involved in the child welfare system also have domestic violence that's going on, or might also be receiving substance abuse services. Really critical information, but we've never linked across those data systems. And the other reason that I think we're just beginning to kind of adopt this more public health and health-oriented focus is that for a long time we didn't have strong longitudinal research that allowed us to really see the consequences of child maltreatment. And increasingly the research has just been growing, and there is no doubt that child maltreatment is a huge risk factor for a number of very adverse adult outcomes as well, in terms of mental health, heart disease, you name it. And so those connections have really caused people to say, if we are able to kind of prevent child maltreatment initially and prevent its recurrence among those where it's already occurred, then we are going to be very, we may in fact see quite a large impact in terms of longer term health. And so a public health model basically says, listen, we need to have good data collection and surveillance, and that surveillance cannot be limited to just the population known to a given agency or service delivery system. We need to identify those risk and protective factors that are operating. We need to then develop and test prevention strategies, and we then need to kind of not only disseminate those, but also continue to collect data that allows us to figure out, is this working for all populations, or do we need to tweak things? So, what have we done with these data? The first part is going to be targeting services. That's what I'm going to address with you. And before I do that, I want to quote my son. A few of you, when introducing yourselves, said, oh, I'm just a parent, which of course is about, I think parenting is the toughest job, and of course that's why we're all here, to figure out ways that we can help people to parent better. And I don't think that anyone captures it better than my son, who at one point asked what research I was doing and if he could help. And I was in the middle of a paper, and I said, sure, why don't you contribute a paragraph to it? And I explained the research I was doing, and this is what he said. Parents should be nice to their babies and take care of them. If the mommy and daddy don't know how, we should teach them. But if they're still mean and don't keep matches away and don't know where the baby is, we should call the police or the fire department and find the baby new parents. And I have to tell you, I think that the words of a 5-year-old capture it pretty well. And one of the things that we have not yet been successful at is striking that delicate balance of how do we help support parents to parent, while at the same time protecting children from harm. And I think that the work that we've been doing hopefully gets us a little bit further along in that domain. I'm going to start first by how do we help parents to parent, and one of the things these data would suggest is that we can tell on the day that a child is born the likelihood they are going to later be reported for maltreatment. And if we know that, isn't there something more that we can do to support that parent and that family right at birth? Okay, so after linking up all these data, and it's a good thing my time as a doctoral student was very cheap, because I have to say, well, the computers did a lot of it. We're still talking about 4.3 million records. So what I wanted to do was look at, there's all this information on the birth record, family information, pregnancy information, child information. If we can look at every child who's born, can we develop a predictive model that tells us which of these children is likely to be reported before the age of 5? Because if we can do that, can't we do a much better job at identifying them and targeting them for supportive services? And when I say targeting, I don't mean anything coercive. I mean offering them services. So what are some of the variables that are available in the birth record and that I was able to look at? Well, one is child sex. Birth weight, so I was able to look at, was the child less than 2,500 grams or more than 2,500 grams? That shows up in the literature as being a risk factor for maltreatment. Could look at prenatal care, when that began for the mother. Was there a birth abnormality present? Was the mother born here or else, or was she foreign born? I could look at race, maternal age, maternal education, pregnancy termination. And I want to say that for all of these variables, they should not be interpreted as causal in any sense. Basically, what we're looking for are there variables in the birth records that proxy other things? So in most cases, let's take the example of prenatal care. We don't think that not receiving prenatal care until the 3rd trimester causes a mother to then maltreat her children. What we think is that when we see mothers where maybe there was no prenatal care or very late prenatal care, there may have been something else going on. Maybe there was a mental health issue. Maybe there was a substance abuse issue. Maybe there was an access issue and it's not at all connected with her capacity to parent. But that's what we're looking for with these variables is, are there kind of socio-demographic markers of risk? And so, for example, with pregnancy termination, that's one where there have been a few other studies that have suggested that a history of pregnancy terminations is a risk factor for maltreatment. So we decided to kind of go ahead and throw it in the model. Named father is another one where it was actually quite fascinating to me. On the birth record, you can get social security numbers, you can get very personal information about termination history and whatnot. You actually cannot get whether or not the parents were married at the time the child was born, but a father cannot be named on a birth record unless he is either married to the mother or shows up at the hospital and says, this is my child and I am willing to establish paternity, okay? So what we were able to do then was look at, were there children where there was no father who was showing up and claiming paternity right at birth? We could look at the birth order. We know that falling later born and living in larger families is sometimes a risk factor for CPS involvement. And then we could also look at birth payment method. So was this a birth that was covered by public insurance or private insurance? That's another classic example where do we wish that we had more refined income information, since there have been there are gradations in CPS involvement by income? Absolutely, but this got us part of the way by being able to look at public versus private insurance. Okay, so what did we find? These findings are from the 2002 birth cohort, okay? The findings emerge across all of the birth cohorts, but just to put this in perspective, there were around 540,000 children born in 2002. Before the age of 5, around 74,000 of those children had already been reported to CPS for maltreatment. So that's about 14% of all children born. It's much higher than I think that we'd previously appreciated, because what we tend to do with the data is we look at what is the prevalence in any given year of children who have contact with the CPS system, and that's much lower. But if you look at kind of, you can have a low risk in any given year of being reported for maltreatment, but over the course of a 5-year period, what we see is that 14% of children were reported for maltreatment. And it's probably higher than that because I wasn't able to match all records. So there were some children where I couldn't find a birth record for them. They may have been born elsewhere and moved to California, or it may have been a mismatch. So I think 14% can be considered a lower bound estimate. 35% of all those children who were reported during infancy. So they were known to the child protection system during that first year of life, where developmentally we know that so much is going on with children and where there's so much that could be done. And of those children who were reported during infancy, 25% of them were actually reported within the first 3 days of life. So basically before they left the hospital. Yes? You know what, it just happened to be that two things. One is that I was primarily looking at fatalities, and what we see is that 75 to 90% of children who die from maltreatment-related fatalities die before the age of 5. And then I also have just been very interested, it's kind of the first 5 thing, I've been very interested in what we can do on kind of the front end, but we are planning on extending these linkages so we can actually look at what is the cumulative risk of CPS involvement anytime between birth and say the age of 18, which is something that with earlier birth cohorts we'll be able to do. Okay. And then again, within the first 3 days of life, what we found was that 11 of those 12 variables that I just listed were significant in our models, which meant that it did give us more information as to whether or not the child was likely to be reported for maltreatment. What's the one variable that wasn't predictive? Gender, yeah. So gender is one which we always kind of throw in our models, but we generally do not find that there are significant differences in the likelihood of being maltreated between male and female children. And then what we observed is that 7 of the variables had crude risk ratios above 2. So what does that mean? It means that if you had that characteristic at birth, you were twice as likely to be reported for maltreatment as another child who otherwise looked the same but didn't have that risk factor. And so those kind of 7 variables were the ones that we wanted to look at a little bit more closely. But first I just want to walk you through a few slides that highlight that while we think about that 14% of children in the birth cohort being reported for maltreatment, and it sounds large and it is large, that is actually an understatement for certain groups. So it masks important variations by some of these risk factors. So let's just take a look here. If you look at these first 2 bars, among those children where there was no paternity established on their birth record, 1 out of every 3 was reported for maltreatment. So over 34% of those children were reported for maltreatment, compared with just 12% of children where paternity was established. This is very consistent with a larger, kind of a growing body of research as well that suggests that it's not actually being a single mother that heightens a child's risk of maltreatment. It's having an unrelated male caregiver in the home that heightens a child's risk. And so, one way of thinking about this is if we know that there was no dad at the hospital at birth kind of claiming this child as his own, then there's a much greater likelihood that there is at some point over the next 5 years going to be an unrelated male caretaker or caregiver in the home, and that clearly heightens risk. Another thing to say about that is in the overall birth cohort, only 9% of children didn't have a father listed on the birth record, so it's actually very rare. But among those children who ultimately end up entering foster care, we're finding that almost 50% of them don't have a father listed. So it's also a risk factor where it's a risk factor for being reported, it's a risk factor even more so for being substantiated, and an even greater risk factor for entering foster care. In terms of public insurance versus private insurance, we see that 21% of children who were covered by public insurance were reported for maltreatment, compared with only 9% of those with private insurance. We can see a graded effect with prenatal care. Okay, so we see that fully almost 50% of mothers who gave birth without any prenatal care were reported for maltreatment, down to 12% for first trimester care. We see a similarly graded effect based on maternal age. Again, this is stuff that shows up in the literature. We know that being a teen mother is a risk factor for CPS involvement, but we see it very clearly. 1 out of every 4 babies born to a teen mom will be reported for maltreatment before the age of 5. And then we also see dramatic racial variations, which have also shown up in the literature, ranging from 35% of Native children being reported for maltreatment before the age of 5, down to 5% for Asian Pacific Islander children. So what we decided we would kind of play around with, and I would say that these are just very much kind of back of the envelope type calculations. So we plan on doing some more significant modeling. But what we thought about was, okay, so what if we could use a simple checklist on the day that a child's born, an epidemiological risk assessment tool, and we basically count up the number of risk factors they have, and then we determine what types of service interventions we may need to provide, and also where they should fall in that kind of triage of service offerings. So what we looked at were those risk factors that were both theoretically modifiable, which meant that we thought there was something that could be done from a policy or practice perspective that might shift the distribution of risk factors in the overall population, as well as those risk factors that were most strongly correlated or predictive of CPS involvement. So what we did is we classified every child as being high risk if they had 3 or more of these risk factors. Because what we found, and I know that this has shown up in some of the other literature and other talks that you've heard, is that it wasn't just being poor, and it wasn't just being a young mom, and it just wasn't just not having a dad listed on the birth record. What it was the accumulation of multiple risk factors that presented significant burdens for the parent and family and made it very likely that the child was going to end up involved in the system. And so what we did is we looked at the following. Was there late prenatal care? So prenatal care that started anytime after the first trimester. Missing paternity. Less than or equal to a high school degree. 3 or more children in the family. Maternal age of less than or equal to 24 years, and a publicly insured birth for a US-born mother. And what we found is that there was only 15% of all children born in California had 3 or more of those risk factors. Okay? A huge percentage had 1 risk factor, and many had 2 risk factors, but only 15% had 3 or more of those risk factors. And yet that translated into over 50% of children who were reported for maltreatment. Okay? So it means we're not getting everybody, but imagine if we were successful at providing early intervention services to that kind of narrow slice of the overall birth cohort, that 15%. What could we do to then prevent at least some fraction of the 50% from being reported for maltreatment? The other thing that we found, and this is what I was talking about in terms of the cumulative risk factor count, we literally just counted up how many risk factors did a child have. And we found that a child who fell in the low risk category of all those kind of groupings that I just talked about had only a 3% probability of being reported for maltreatment, whereas a child who fell in the high risk category of all had an 89% probability. So some of this comes down to kind of a policy question: where are we going to cut the line and devote resources? Is it children with 3 risk factors, 4, 5, 6? But these data suggest that risk increases dramatically. Yes?
If you flipped the population, where instead of looking at the cohort, you looked at the actual CPS population, kids that were reported or families reported, are there the linkages? Is it like 85% of that population has 3 or more of those risk factors?
Well, so that's what we found with this right here.
Okay.
So when we flip it, okay, right, so when we look at all the children who are known to CPS, we see that half of them have 3 or more of those risk factors. And that's a good question, because what it's important to remember is that it's a high-risk population of children and families who end up involved in the CPS system. And within that population, it's very hard to predict who's going to have a repeat report, or who's actually going to enter foster care. But when we look at those children within the context of the broader population, that's where that unique profile really emerges. And it is a profile that's defined not by 1 or 2 risk factors, but by multiple risk factors.
My only follow-up to that is that it's always confusing to me, because when we do presentations on child abuse, we talk about it as an equal opportunity problem. And yet whenever we discuss it in research, it always seems to fall into the same high-risk categories. So it's very confusing to me how to play that, how to understand that.
I totally hear you on that. And I think that what I would say in response is that, when we look at these data, we know that there are a significant number of children who are reported for maltreatment and are at risk, who don't fit into that sociodemographic profile where we have lots and lots of risk factors. Those children in those cases are much harder to predict. But what we also know is that there's no doubt that poverty is a huge risk factor for maltreatment. It kind of makes sense. I mean, if you think about what parents need to parent, they need human resources, they need social resources, they need financial resources, and they need kind of broader community and environmental resources. And if a parent is parenting in an, where they are deprived of any of those, of course it just intuitively makes sense that the risk would be elevated. But I do think that there have been some politics around how we present child abuse historically. So no, I appreciate that comment. Just quickly, because I do want to get to the mortality findings. So, I am in no way suggesting that we can just have some standardized risk assessment tool that we administer at birth and we're going to stop there and we're going to know, oh, you have 3 risk factors and therefore, we need to offer you services and you really should take them because you're going to maltreat your child. But what this can tell us, I mean, listen, I would love it if we had the funding to provide early intervention, home visiting services to all new mothers. Trust me, I have 3 kids. I would have loved it, right? But we know that that is unlikely to happen. And as much as we are functioning in a society where there are constrained resources that are devoted to maternal and child health, using data to think about those children and mothers and families who are at highest risk would seem to make a whole lot of sense. And so that's kind of there. What have we done with these data? Part 2. So this comes from the before. What did these children look like before? And now I'm going to talk about some of the fatality findings. So I was really interested in child maltreatment fatalities in part because, yes, it's the ultimate preventable tragedy. And so as a system, you are trying to prevent that tragedy from occurring. But also because, again, I was really interested in who does the CPS system have contact with? Is it just that we are overstretching and we are kind of pulling into our net all of those poor families who have some of those risk factors I was just talking about? Or are we actually picking up children and families who are at some elevated risk of a negative outcome? And well, the most negative outcome, and in many ways the most objective marker of an absence of well-being, is a fatality before the age of 5, particularly if it's a preventable fatality. In California, especially in kind of the LA area, of course, I don't need to tell you about what the response to child fatalities typically is. So what happens is we often see, there's a maltreatment report that comes in. Unfortunately, the child dies. There's public outcry, public hearings, a child welfare director may be ousted, and there's agency redesign, and then it starts all over again. And in my mind, one of the reasons that has happened is because we have not had the broader epidemiological data that we needed to really make informed modifications to practice and policy that would allow us to prevent child deaths. So a lot of the work that we've been doing has been based on the findings compiled by child death review teams who look and review all the deaths of children, including those who are known to CPS. And it's really important work, okay? But what it doesn't do is it doesn't give us information about all of the experiences and characteristics of children who maybe had the same contact, the same decision was made, but they didn't die. So it doesn't provide that broader epidemiological perspective that would allow us to really figure out what needs to be changed. An example would be, let's say that we look at a child death review team is reviewing deaths and they see that in 50% of fatalities, if you go back, you see that there was domestic violence in the home. And I have no idea, that might be the number. So that would seem to be a significant risk factor. But what we don't know is maybe in 50% of all cases where children had maltreatment and were involved, there was also domestic violence. So we don't know if domestic violence actually elevates the risk or not when we look only at those deaths that have occurred as opposed to children who did not die. So let's see. What I did, and I'm just going to go through this very quickly because I think I'm running out of time, I looked at injury deaths. I looked at not only those that were classified as inflicted or maltreatment related, because there's a large body of research that would suggest that those are significantly and severely undercounted in the death records, but I also looked at deaths that were unintentional, which made sense to me. 75% of kids who are reported to CPS are reported for reasons of neglect. Why do we think that a neglect case would lead to an inflicted injury fatality as opposed to an unintentional injury fatality, where maybe there wasn't the appropriate level of supervision or surveillance because a parent was intoxicated or not in the home? So I looked at both unintentional and intentional injuries. I looked at the allegation type, so I wanted to see, are children who are reported for neglect at greater risk of death than children reported for physical abuse? Is there anything there that we can kind of glean from the information that's available? And then I was also able to make adjustments for sociodemographic risk factors, which is really important, because that same list of risk factors that I showed you that predicts or that tells us which children are at greatest risk of being involved with CPS show up for the fatalities. So those are the same risk factors for an injury fatality. So first question, are children reported for non-fatal maltreatment at greater risk of injury death before age 5 compared with sociodemographically similar children who are not reported? Okay, so this is saying you have two children who at birth look exactly the same. Maybe they each have 4 risk factors, but one of those children has been reported to CPS and one has not. Which of those two children is more likely to die before the age of 5? And the answer is that after adjusting for all of those other risk factors, so again, I'm looking at two children who look very similar to one another, the single strongest predictor of an injury fatality before the age of 5 was a prior report to CPS. Okay, a lot to see here. I want you to just look at the red line here and the red number. What this tells us, this is looking at all injury deaths, and what this tells us is that children who were known to CPS died at 2.5 times the rate of children who were not known to CPS of injuries. So this is all injuries, so 2.5 times. When we look at unintentional injury deaths, or all those that are considered, quote, accidents, we see that children with a prior CPS history die at twice the rate of children in the population who've never been reported. And we see the strongest difference when we look at intentional or inflicted injury deaths. And there we see that children who have a prior report to CPS die at almost 6 times the rate of children who have not been reported for maltreatment. Okay? In some ways, I don't find this all terribly disheartening. In my mind, it would almost be worse if we didn't see that a prior report to CPS was a risk factor, because then it would tell us, listen, we're just picking up kind of poor families at random. We're kind of intruding into their kind of private lives. We're investigating. We're doing whatever else, and yet they are actually not at any greater risk. Okay. What this tells us is that a report to CPS is an independent signal of a child's risk. It tells us something that all those other risk factors couldn't. Maybe it means that there's a new boyfriend in the house and it's kind of dangerous. Maybe the report comes in because mom has relapsed. I can't tell you exactly what it is, but it tells us that it is an independent signal for risk. And why that's relevant and why that's helpful to know is that it also highlights the importance of the work that we're all doing and that child welfare workers are doing, because it suggests that these are highly, highly vulnerable children, and we know that just based on a report. It doesn't need to be substantiated. These were all reports. Second question. Have you guys, yes?
How might you look at children who, I work in a hospital.
Okay.
So I review every child that gets injured that comes to our emergency room. Knowing that, I mean, does it kind of work the opposite way? I mean, should we always be sort of a little suspicious about kids who come in with unintentional injuries at the age of 2 and then look for those other risk factors? I mean, how might this translate in the real world?
That's a really, really good question. And one I don't have a perfect answer to, frankly. I think what it comes down to is that there's been some research. It's very specific. There has been some research that suggests that almost all unintentional injuries of a certain nature that involve a child under the age of 1 do reflect Not necessarily abuse, nothing that would necessarily be criminal, but some aspect of negligent caretaking and caregiving. And so is there something that should be done as a follow-up regarding parent education or support? The answer is probably yes. I think the other thing to remember is that what you really need to pay attention to, I think, are patterns. And that's where it's unfortunate when we don't have fully linked data. Because maybe it is that again, I've been at the ER with my children, but what you assume is that there's a randomness, and this sounds terrible, but does a child die the first time they're thrown against the wall, or the 10th, or the 20th? There's a certain randomness to when that fatality occurs, but if you see that there are dramatic differences in groups in those eventual fatalities, then you assume also that the exposure has been different. And so that's where I would kind of look more at, is this a kind of a first visit to the ER for an unintentional injury, or are we starting to see a pattern for this family? And I think most of the research would suggest that if we do look back at the ER and hospital records, we often can find that there was a pattern, but that the family was floating between different hospitals or different service providers, and therefore there was not a complete record that would allow us to kind of tease that out. Okay. Okay. The other question I had, and many of you, if not all of you, maybe have called in a report to CPS. Of course, you know that what happens is that some of those reports are screened out at the point that the call is made. They're called evaluated out or screened out, and that means that there's no in-person investigation. And what we're finding is that those children behaviorally down the road look very similar to those children who did receive an investigation. We're finding that their rates of being re-reported are equivalent. So in California, over 40% of children who are evaluated out, guess what? There's another report that comes in. And so what I wanted to look at were did these children have higher rates of death than other children? And what we found was that, I framed that wrong, did these children have at no greater risk, so kind of a double negative there, sorry about that. But what I found was that children who were evaluated out died at 2.5 times the rate of unreported children. Okay, so to assume that because a report of maltreatment has been screened out over the phone, the child is not at risk, would seem to be very ill-advised. And we found that children who were evaluated out had rates of death that were equivalent to those where there was an investigation. So, my takeaway with this is that for children under the age of 5, again, it's that report of maltreatment. Someone's concerned, someone's saying that there's something that may be endangering this child, and the data would say that on average that is correct information, and that in-person investigations of children under the age of 5, in my mind, might be a good use of our resources, rather than thinking that we can gather the information we need over the phone. Final kind of point that I want to make, looking at children reported for non-fatal maltreatment, does the risk of injury death vary by the maltreatment type? Okay, so in my mind there seem to be logical conceptual connections between neglect and unintentional injuries and physical abuse and inflicted or intentional injuries, and in fact that does play out in the data. So what we found here was that children with a prior allegation of physical abuse had the highest overall injury death rate, and it was most pronounced for inflicted injuries, and rates of unintentional injury death were higher among children reported for neglect. So in looking at these data, what we can see is that when we look at all injuries, children who had a prior report of physical abuse died at 1.7 times the rate of children who had been reported for neglect. When we looked at inflicted injury deaths, those children died at 5 times the rate of children reported for neglect. And when we looked at unintentional injury deaths, children reported for physical abuse actually had a lower risk of death. Okay, so the rate was higher for neglect. Makes intuitive sense, but in my mind, what also would make intuitive sense is only about 12% in California of children under the age of 5 are reported for reasons of physical abuse. And if we know that those children have an elevated risk of a fatality before the age of 5, should we be doing something different with those cases in terms of monitoring, screening, a simple red flag that maybe says this case may need a little bit more supervisory oversight, because we know that it's physical abuse, the kids under the age of 5, they're very physically vulnerable, and we know that the chances that this case turns into one of those terrible fatality cases is greater than a case where neglect has been alleged. Okay. Next steps. I've presented data kind of highlighting some of the information which can be generated just from simple linkages with vital records, which we are continuing and expanding. I think we need a lot more data integration, and I realize that that's not something that you guys are going to be working on, but hopefully your appreciation of what types of information can be generated from linkages such as this. So right now we're working on some linkages with emergency department and hospitalization data, so we can better understand even things like racial disparities. If we have a white child who presents at an emergency room with a certain type of injury versus a black child, who's more likely to be reported, and when we actually follow up, where is it more likely that maltreatment occurred? So looking at some of those questions, better understanding other services that the family may be involved with when it comes to education, mental health, alcohol and drug, and then horizontal linkages with data that will allow us to look at some of those outcomes that will inform our understanding of how the CPS system is faring. So that's what we're working on, and that's kind of the longer term vision. And now I just want to open it up to questions, comments, thoughts. Yes?
Have you presented this data to Department of Child Protective Services or DCFS or any of those?
I have. So we've presented the fatality findings and the birth findings to CDSS, and we have also presented some of the findings to DCFS. You know, I mean, a lot of these findings, they feel kind of intuitive. I think what's hard is that we're talking about other systems. So, you know, when we talk about maybe early intervention and work that could be done with these children and families at birth, we're not necessarily, the CPS system's probably not going to have the resources to be able to provide those services. So that's where we really need to engage our public health, maternal and child health partners in that work, but hopefully kind of, you know, informed by what's impactful for DCFS. So I think it's about engaging other partners. I have a meeting coming up with First 5 LA where they were very interested in some of this work. So it's all kind of, frankly, it's all kind of new, but we are trying to engage a lot of partners and hopefully get people to think about it. Yes?
I have a comment. Working with family preservation, our funder is DCFS, and there are policy changes around this information. We are looking more closely at families that have children under the age of 5. We're also instituting what we're calling intensive family preservation, in which the high-risk under 5 children are receiving more services. So we are now tasked to go out to the home at least 5 days out of the week. So there are some really great policies that are being instituted to protect children. But you're right, DCFS can't do it all, and I can't speak for them, but as far as our program, we are being tasked to do more in terms of protecting children and monitoring the home and the parents.
That's terrific to hear, and what I would say is that these data don't tell us whether the services we're currently offering actually work or not, and it could be that the reason we see that those risk factors translate into only 50% of the kids who are reported for maltreatment is partly because we are picking up a lot of those other children who have risk factors with services, and maybe we're preventing that contact from occurring. So yeah, I think that's an important next step in terms of better understanding what services are being provided so that we can see what's working. Yeah?
A couple of comments. One, I'm part of a multicultural health group at the state level, and there's a big push to disaggregate the Asians with the Pacific Islanders, and we have a big Pacific Islander community here, so I wonder if you have any plans to do that. And second, I work in Orange County, and they won't even tell us at their county whether or not there's a history, whereas LA County you can call and find out. So that really hobbles us if we're trying to look at these risk factors. I don't know if you've worked with them at all.
I have not. So to answer your first question, Asian Pacific Islander, it's something that's definitely come up. It's not something I think that we're doing in the immediate future. What we found has been really interesting is that from the birth record, we can now kind of look at Latino families and look at whether or not the children were born to US-born mothers versus foreign-born mothers. What's very interesting about that work is that in California, we've historically said that there is an overrepresentation of African-American families, but that Latino families look just like white families in terms of their contact with the system. And what we find is that's actually not true, that the Latino population is heterogeneous, and that, that what we find is that Latino children of US-born mothers have rates that are much higher in terms of overrepresentation to the African-American rates, and it's the immigrant families who have very low rates. And so you've got one group with low, one group with high. Now, of course, with all these racial findings, that doesn't tell us whether or not the level of surveillance is what it should be. I mean, this could be that we're picking up certain, it could be that the immigrant families do have high rates of maltreatment, but they're kind of flying under the radar, and there are certain groups where the longer they've been in the U.S., the more likely they are to have contact with mandated reporters. We don't know that, but and I don't know what to say about the the data sharing piece. That's what reason do they give for not disclosing?
And I had a kid with that pattern who'd been in the ER 5 times. She was 24 months old. 3 of the times were unwitnessed falls, broken wrist at 18 months old, and they didn't take it.
Yes.
I'm glad you brought up First Time LA, where I've worked for the past 5 years in the public policy department. And so there's profound interest in all of this from a public health standpoint. And so some of my questions will kind of relate to that. So one is nurse-family partnership model looks at first-time mothers.
Yeah.
And I heard you saying that 3+ was a factor that was verified. Should there be an adaptation there or another model?
I think what's very interesting about some of these early intervention programs is that I don't know how to put this nicely. I think they tend to cherry pick a little bit, and so even the very design is picking at-risk families, but not super high-risk families, because the super high-risk families are very difficult to engage, and it's very difficult to produce good results because we haven't yet figured out what works. So I think that what these data would suggest is that I don't know that it's that the model needs to be changed as much as we need other models that maybe are targeted not to just young mothers with one baby, where it's an important group to target, but we need other models that are targeted more to kind of multi-problem families, recognizing that we're probably going to have to spend more money, that it's probably going to be that we need more intensive services, the 5 days a week, that we're probably going to need to be engaged in that family over a longer time horizon. And I don't think that we've yet made those investments to figure out exactly what it is we need to do to produce results.
Another question is about electronic medical records, and will that, when that gets implemented, will that help with the tracking of the ER patterns?
I don't know. You don't think so?
Not if we have ours. Maybe some of the better ones.
They're different across, they're just per organization, so they don't always cost on.
Oh, but they are looking to link everybody. I don't know how they're going to do that.
It's very hard.
I mean, I think part of what we also have to keep in mind is that we're not going to be successful at better decision making and better assessment if we're just throwing data at people either. And so it's how maybe things are going to be electronic, and that's great, but we need it to be in a form where a worker who's doing an investigation, I mean, ideally, in my mind, would have an iPad in front of them. They can immediately pull up, were there any kind of contacts with the police over the last however many days. They can access all of the information they might need to inform some of their decision making right there. I think that the more we're moving to electronic records, that's positive, but I don't know that it sounds like it probably will not be anything that has an immediate impact.
Well, I just have one question for you. In terms of intervention, I've been reading a lot about strengthening families and the 5 protective factors. Do you have an opinion about that? Because my understanding is that the research supports that these 5 protective factors actually, when they're incorporated in the intervention, will produce better outcomes. What is your opinion about those 5 protective factors and the literature?
You know, I'm going to have to plead ignorant on this one a little bit. I am familiar with the Strengthening Families work, and I have seen the 5 protective factors. Can you remind me what they are? I mean, I'm not going to remember them off the top of my head.
Resilience, overall well-being, or social education for parents, to basically teach them about the developmental stages, basic resources, community linkages, and I'm missing one.
Okay.
Thank you. Social isolation.
So, you know, I mean, my kind of off-the-cuff response to that is that they intuitively make sense. I think where I struggle, and I think they're meant to be somewhat inclusive, is how do you promote those? I mean, there's no kind of prescriptive formula for how you promote kind of greater parental resiliency, right, or kind of shift that. So while I think that the protective factors make sense and provide a nice framework for organizing the work that we're trying to do, we still need to know what are those evidence-based practices that actually kind of advance that. Okay. Great. Thank you so much.
Wow, Emily, thank you so much. There was never a day I was so grateful that Paul Krugman is here to videotape this. And Emily, thank you for mentioning that Paul Sharp, who was formerly our videographer, has started collecting a library of these talks that we've done. And with the speaker's permission, he's linking them to our website. So if you go back through our program schedule, not only now do we have handouts linked to the former schedules, but also we have, with the speaker's permission, we have links to presentations we've had here before. And with Emily's permission, we'll have this one linked up, and you'll be able to share it with your colleagues. And Emily, we're just so very grateful for the work that you've done. I was mesmerized. It was just fabulous. Thank you so much. And thank you all for being here. Your September program is in front of you. We look forward to seeing you in September with the SIDS topic. Yes, you have your yellow papers in front of you. Please nominate a colleague or a friend or a co-worker who is working in this field whom you think is worthy of our award in December. And thank you all so much for being here this morning.